Okay, so as you said, thank you for the invitation. I'm talking about unilateral hemilaminectomy and a bilateral decompression in cervical spondylotic myelopathy. And I would give you some clinical data, radiological data, and also some biomechanical data. If we are dealing with cervical spondylotic myelopathy, normally we have two common surgical options, which are either the anterior decompression, which is done by ACDF with or without plate, or by anterior corpectomy, or we have the posterior decompression option, which normally is done by laminectomy and fusion, or by laminoplasty. If you're looking into the literature, you can clearly see that there's no better approach. This is a very nice randomized controlled trial, which had been published very recently. It compares the anterior decompression with a posterior decompression, and we have very similar data, comparable data concerning the NDI, the quality of life scores, and also concerning the modified JOA score. So there's no difference in terms of clinical improvement after surgery. And if we are looking into the complication rate, again, we have a similar complication rate, similar percentages with a slightly different complication profile. If we're talking about posterior approaches, we are always thinking about problems of the bilateral detachment of the cervical muscle insertions and about the B-level detachment of the interspinous ligament. And we always fear loss of lordosis or the development of a kyphosis. And we thought also about the problem, and we are looking for an alternative. And our alternative, which we came up, we took from lumbar stenosis surgery, namely the concept of unilateral laminectomy and bilateral decompression. We published How I Do It in Acta Neurosurgery 6 years ago, and hopefully the video is running, which shows you how we're doing it. No, it doesn't work. So I go back. So what we are doing is a midline skin incision. It's a unilateral incision of the muscle fascia. Then it is an ipsilateral detachment of the muscle, and we are performing an interlaminar fenestration, a laminotomy, or if you're dealing with more than one segment, we are going on with 1 or 2 level hemilaminectomy. And then we are undercutting the spinous process, and we are doing the undercutting process on the contralateral side. In our opinion, it's very important to see the beginnings of the nerve roots on both sides, and then you're sure that the decompression process is sufficient. This was our concept, our idea, but then we tried to prove that this is a valid alternative to other approaches. So we make a prospective non-randomized study. We collected prospectively cases. These have been the inclusion criteria. There have been patients with clear cervical spondylotic myelopathy with symptoms, and we have clear exclusion criteria, especially unrelated neurological symptoms such as cerebral or spinal diseases, psychiatric disease, previous surgery, and pre-existent kyphosis, which in my opinion precludes to perform a posterior surgery. This is how we have run the trial. We make a pre-op visit with MRI, with CT scan. We collected the NDI and JOA score data. We repeated directly after surgery the CT scanning and the clinical parameters, and we checked the clinical parameters after 6 weeks, 6 months, and after 1 year. The CT scanning before and after surgery was performed to measure the spinal canal volume, respectively the spinal canal volume gain. We finally ended up with 44 patients. Now we have in our prospective trial more than 70 patients, but these 44 patients had been evaluated for 1 year. We have seen that in our series of 44 patients, the majority of the patients have had no hyperintensity in the spinal cord, as you can see it here. So the different grades. 12 patients have been a blurred increase of the signal intensity, and 7 patients have a very intense increased signal intensity, which is more point to myelomalacia. We operated in 1 level in 15 patients, in more levels in the remaining patients, and on the right side you see a CT reconstruction, again showing the amount of the bony removal. The bony removal by this type of surgery is, in our opinion, quite good. The mean preoperative stenotic volume was 5 centimeters, and we have been able to increase this volume by 30%, which proved to be significantly more than before surgery. So we have been successful in enlarging the spinal canal. The same holds true with the clinical data. We have a significant improvement of the JOA score, which went up from 12 preoperatively to 13 over the next months. And here you can see the improvement rates of the JOA score, which was between 20 and 30% in 1 year. And the same holds true with the NDI. It's not surprising that directly after surgery, the NDI went up, but afterwards it dropped. And these data have been sometimes significant and sometimes not. We also have seen, and this is not surprising, that we have a clinical improvement which dependent on the amount of the changes, the hyper intense changes in the cervical spinal cord, with better improvement rates if there was no signal change. However, we have shown that the enlargement of the spinal canal was good, but we didn't know if this enlargement is comparable to the enlargement, let's say, after laminoplasty. As we have performed laminoplasty before we changed our surgical strategy, we had been able to match our prospective data collection with our retrospective data of open door laminoplasty. This is how we perform open door laminoplasty. We published this last year, again in ACTA. In this matched pair analysis, we had been able to have 19 patients per group. The baseline characteristics had been quite similar. The mean preoperative spinal canal one was smaller in the mere decompression group, and it was a bit larger in the laminoplasty group. And this is, I think, the most important slide concerning this part of our investigations. We have been able to achieve a volume gain in both procedures, but there was a trend to a greater volume gain in the mere decompression group via 1 unilateral laminotomy, which shows that at least from the radiological standpoint, let's say the mere decompression was a bit better than the laminoplasty group. So our first conclusions after these clinical and radiological studies have been that this technique of unilateral laminotomy and bilateral decompression is feasible and also a safe surgical procedure. There was no neurological worsening. This operation also improved the symptoms of cervical spondylotic myelopathy. Enlarges significantly the spinal canal. The enlargement is at least as good as with laminoplasty. However, what we didn't answer in our 2 clinical trials was the thing if possibly this procedure destabilized the cervical spine, and therefore we decided to go for a biomechanical study in which we tried to answer the 2 things. Namely, that the degree of bony decompression destabilizes the cervical spine, thereby increasing the risk of kyphosis, and that the degree of bony compression compromises the stabilization effect of dorsal inflammation if it had been done. So we took 6 human cervical spines. It was a native specimen with intact facet joints and intact ligaments. And radiologically, we excluded any bony abnormalities and osteoporosis. And in the lab, we made investigation with flex extension, lateral bending, and axial rotation with a loading of 2.5 Newton meters. And we look for the range of motion and the neutral zone. This had been the segment conditions, the situations we compared. This is the native specimen. Then we performed the unilateral and the bilateral decompression. We added a unilateral fromentomy. We added a bilateral fromentomy, and finally performed the laminectomy. And every of these conditions had been added then with a fusion. And all these situations, all these different segment conditions had been compared. These are the findings, and we could show concerning flex extension that none of the bony decompression procedures changed the stability of the spine, and the same holds true for lateral bending, and the same holds true for axial rotation. And therefore, we came up to our second conclusion that this type of surgery with unilateral laminotomy and bilateral decompression is not destabilizing the cervical spine. And you also can add uni or bilateral fromentomy without any further destabilizing effect. So our summary was that unilateral laminotomy and bilateral decompression in the undercutting technique should be at least considered as good treatment option for posterior decompression in cervical spondylotic myelopathy. Thank you.